The next Science Night Live lecture is February 15th for Darwin Day, same time, same place. So we're really excited about that. There will be, my understanding is, a special appearance by Mr. Darwin himself, which is always very exciting. So it's my pleasure tonight to introduce Dr. Corinne Kyriacou. She is an associate professor in the School of Health Professions and Human Services here at Hofstra, and where she teaches courses in the Hofstra's Masters of Public Health program, the Master of Health Administration program, and undergraduate health sciences and community health programs. She is the founding director of the Masters of Public Health program here at Hofstra University, which she directed from 2012 to 2016, and led the effort, the successful effort, to secure accreditation from the Council on Education for Public Health, which is a big deal. Yes, indeed. Dr. Kyriacou's research focuses on finding effective strategies for integrating medical and social services to create a more comprehensive, less fragmented healthcare system. Prior to coming to Hofstra, in 2004, Dr. Kyriacou spent 5 years as Director of Research at Metropolitan Jewish Health System, a continuum of healthcare provider of services for the elderly and chronically ill based in Brooklyn. She earned a doctorate in social policy and health services research from the Heller School at Brandeis, where she was an Agency for Healthcare Research and Quality Fellow. She also holds a master's in public health degree from from the New York Medical College. And in 2013, we're really proud of this one too, she was named Teacher of the Year for the School of Health Sciences and Human Services. I'm really excited for this lecture tonight on extending the human lifespan, implications of an aging population. Please join me in welcoming Dr. Kyriacou.
Hello, everybody. Thanks, Bob, for inviting me to speak tonight and as part of the Science Night Live lecture series. I was really excited to put together this presentation because it gave me the opportunity to reflect on some issues that are really important to me and to think about the context of some of the research that I've been looking at for the past many years, and as Bob said, on building a supportive and high-functioning healthcare system to meet the needs of an aging population. I find the issue of population aging particularly fascinating because it really operates at the intersection of basic science and social science and political science and economics and public health and health policy, and that's fascinating to me. This is a complex issue that requires complex solutions, and we need to think very seriously about that. So, with that, this is the outline for the talk. I thought I would focus on these 5 areas. First, to kind of take a step back and say, look how far we've come. And then kind of think a little bit about how much further can we go, and I'll offer a little bit of an overview of some of the research happening in life extension. And then talk about some of the ethical challenges, some of the arguments around how much further should we go. And then get into some implications of an aging society and wrap up with what I would like to suggest is a reframing of the discussion about the promises of an aging society. First, a couple of definitions. These terms are often used interchangeably when we talk about how long we can live. Lifespan, a more predictive kind of concept, looks at the average life expectancy for an individual, predictive in the sense that we can really determine or predict lifespan if we look at age and gender, health status, lifestyle, even zip code. Whereas life expectancy is based on kind of average lifespans, and longevity, a more elusive concept, is about an individual's ability to reach a longer lifespan under ideal or prevailing conditions. Okay, so first, in terms of look how far we've come, We need to recognize that we have made incredible strides in extending life expectancy. We've gotten pretty far. We live almost 2 times as long as we did in 1900, where the life expectancy was 47, and today it's approaching 80 years old. So how did we do that? How did we get so far? How did we almost double our life expectancy? Well, some of the factors that are responsible, and there's not one, are related to increased living standards, sanitation, clean water, decontamination of food, improvements in healthcare, new technologies, improvements in disease prevention and in disease management, nutrition. All of these foster longevity and enable people to live better at advanced ages. And birth rates are also declining, which is another success story. And we see that because we have a decrease in child mortality, an increase in access to education and employment and gender equality and access to reproductive services, access to family planning. The result of the decrease in birth rates and the decrease in death rates results in a grayer population, and we'll talk about that. But we should look and think about this as tremendous success. I like this chart because it shows how in the last 25 years we have made great strides in not only expanding life expectancy, but starting to close the historical gaps that exist across different racial ethnic groups. And if you look at the right side of the chart, you'll see that there are some still gaps that exist, and maybe some not necessarily in the direction that you would expect. And so we'll come back to talk a little bit about what's happening, particularly with the Hispanic American population. In this chart, I'm sticking with this idea of look how far we've come. And you're looking at not only a significant decline in death rate from 1900 to 2010, but that we've pretty much conquered some of the leading causes of death that we saw early on, like TB, gastrointestinal infections, and we've reduced mortality from others that still persist, like accidents, pneumonia, influenza. Of course, the chart also shows you that there are growing challenges in terms of cancer and heart disease, which we do not see improvements in. And then there are some newer challenges, like diabetes and suicide. And this really presents new challenges, not only to the healthcare system, but to the social service system as well. But a main point of the slide that I want to emphasize is that we have seen some tremendous improvement. Okay, so how much further can we go? We're living longer. Average age is 80. In many cases, we're living better. We're living well beyond 80 in many cases. And it begs the question, how much further can we go? So, life extension, fantasy or fact? Although we don't completely understand the underlying causes of aging, the extending life research has really moved from the realm of science fiction to mainstream research. While many scientists are still adhering to evolutionary theories that say that we're programmed to begin dying after reproductive or parenting years, and others are saying, well, we might have tapped out. Really, it's not about pushing the boundaries of how long we can live. It's about the fact that we've helped children live to adulthood and to old age. And that's where the success has been, and we don't have a lot more that we can do in that area. Others see promise in the fact that while there have always been people living to 100, the frequency is increasing. And they look at that and they say, well, that's encouraging. We know a little bit about why people are living to and past 100. We know that there are different kinds of interactions between their particular DNA and environmental factors. And we're starting to uncover what can we learn about that. So people see promise there. And they think that maybe we'll be able to make the upper boundary of 120, which the oldest person that we have on record actually is 122, but they say usually the upper boundary is 120. But that is so incredibly rare, as is living to 100, that usually it makes, global news headlines. But some researchers say that shouldn't have to be. That could be the new norm. And there are others who go even further. Others who say, no, there's no upper limit. There's no upper limit. We're at the threshold of a whole new paradigm, they say, replacing our current understanding of where the limits are in human life. And there's some really interesting anti-aging research. It's booming, and at prestigious universities and biotech companies. The National Institutes of Aging and Harvard University have been working at excessive caloric restriction in mammals. And they have found that excessive caloric restriction can slow the process of cell aging. And so they're looking at that in various kinds of mammals and thinking about whether or not we're going to be able to make that leap. However, even though there's some promises with excessive caloric restriction, there's also a lot of downsides. And there are some really negative effects that exist in other organ systems when there is excessive caloric restriction. So there's some new research looking at, well, can we mimic the positive effects of caloric restriction with new chemical compounds? And that's something that other researchers across the country are looking at, actually across the world. Researchers at the University of California, Irvine, and at the University of California, San Francisco, and at the Albert Einstein College of Medicine are leading the effort to find and manipulate genes that can extend life. And they're having some success in this genetic engineering pursuit right now in worms and fruit flies. But we got to start somewhere. And then engineering firms and computer science companies are really busy exploring the potential of placing powerful machines inside the body to replace or improve existing biological systems, building off of some technologies that we are already aware of, cochlear implants and pacemakers. But as we get more and more computer power, and as we get more and more sophisticated with nanotechnology, the possibilities are endless. So while there are only a few researchers who predict they can actually end aging, many, an increasing number, are increasingly optimistic, cautiously but increasingly optimistic, about the prospect of making significant progress in the coming decades. Okay, so given this, how much further should we go? There are many arguments on both sides of this issue, and this is just a couple of them. One argument in support of radical life extension is that aging is not natural, it's a disease that can be cured. And they actually think that perhaps we are doing it all wrong. We're focusing on one disease at a time. We're trying to tackle cancer, we're trying to tackle heart disease, we're trying to tackle different diseases one at a time, rather than looking at the root cause, they say, which is aging. And we should focus there. Another argument is that we've already doubled human lifespan with science, and we should aim higher. And they argue that in 1900, people thought it unnatural to think people could live to be 80. So in 1900, they thought that was outrageous. So if we think it's outrageous today to double the human lifespan from 80 to 120, 140, 160, their argument is, of course you think it's unnatural. That's what people have always thought when something was new and unusual. The people in support of radical life extension also say we should worry separately about welfare disparities, because often they bump up against people who say, well, you know what, there's already huge gaps between the rich and the poor. If we come up with some high-cost biotech solutions that really help to slow the aging process, won't those only be available to the wealthy? And then we'll start to have this huge, even greater gaps between the rich and the poor. And the people that are proponents of radical life extension say, don't worry about that now. First, let's figure out how to resolve this, and then we'll figure out how to create equitable access. On the other side, arguments against radical life extension, the first one is that unequal death persists. That right now, we have a tremendous disparity in the existing life expectancy, both within our country and around the globe, and I'll show you some data on that. And they argue that our time and our effort and our resources and our intelligence has to be really focused on reducing that unequal death and not on extending life for those who have already reached a high life expectancy. There's another argument against radical life extension, which is that we don't know whether or not we're extending more years of debility. Are we extending decades more of mental and physical decline? Or are we extending healthier years? And that's an ethical conundrum we need to consider. Why move forward if we're only extending further illness and debility? And they also argue against radical life extension by saying that any kind of experimentation is going to be risky. Do we really want to go there? Whether we're talking about irreversible kinds of strategies like altering genes, or we're talking about reversible strategies like using hormone therapy, they say that experimentation is not warranted at this time. So I wanted to show you this map because I want to spend a little bit of time talking about the unequal death argument. I feel pretty strongly about that one, and I want to spend a little bit of time digging into that. This map shows that there is substantial variation across the United States in terms of life expectancy, from a low of 75 years in Mississippi to a high of 81.3 years in Hawaii. But what you're actually looking at is how each state's life expectancy correlates to other countries around the world. What you might be surprised to see is which countries we're comparing ourselves to. I think that what's particularly startling about this map is that no state approaches the life expectancy of most European or Asian countries we typically compare ourselves to. At our worst, we look like Syria or Malaysia. And at best, we look like the UK. And we're going to talk a little bit more about how much disparity exists across both the developed world as well as between the developed and the developing worlds. So what drives this state-by-state difference? There are a lot of factors: education, the environment, access to medical care, diet, employment, living standards, violence, lots of things factor into these disparities. And one of the things I'd like to argue is that this is a problem that we really need to focus our energy on. Even more startling, perhaps, is this chart. There is a trend that shows that we have declining white life expectancy. It may look like it's kind of negligible on this chart. What's the big difference, to go from 78.9 to 78.8? But actually, any dip or reversal is significant and surprising, particularly when you're talking about a population that has historically been considered the privileged population. Why is this happening? There are a number of possible reasons. Researchers are pointing to the heroin epidemic, which has exploded, particularly devastating in working class and rural communities, which are primarily white. Heavy drinking, subsequent cirrhosis of the liver, the impact of the obesity epidemic coming to roost, increase in suicide. And what I found really interesting is that a couple of months ago, the Washington Post did an analysis, and they found a correlation between places with high white death rates and support for then president candidate and now President-elect Trump. What I think we're seeing here beneath this chart is a lot of economic pain, a lot of emotional pain. Now, some argue we shouldn't be so focused on this trend. We still have a lot of work to do to bring the life expectancy of African Americans up. But others say this might be a bellwether of things to come for all groups. Disenfranchisement, people feeling disconnected and irrelevant. Other people say, well, let's look at the good news in this chart. Look at the life expectancy for Hispanic Americans. What can we learn there? Their life expectancy is higher. This has been called sometimes the Hispanic paradox, because despite having access to less education, typically more poverty, poor access to health care than whites, their life expectancy is higher. So some argue that this is an effect of immigration, that people immigrated here healthier, and therefore they are continuing on that healthy path, and we will soon see that positive effect go away as we go to second and third generations of Latino Americans. Others point to the fact that there is more social cohesion and more social networking and a greater likelihood that Hispanic families are living together in multi-generational homes. Maybe there is something to learn there, or maybe that effect too will change as we move into second and third generation. Another concern is that the life expectancy at birth in the United States is lower than in comparable high-income countries. Right before I came here, I got an alert on my phone from Health Affairs, one of the leading health policy journals, that there's a new Commonwealth Fund survey out of 11 countries, and they do these surveys periodically. And once again, the U.S. lags behind all other developed nations with more chronic illness, greater levels of emotional distress, greater financial worries, and more health-related barriers to full-time work, which is what we're seeing here behind these bars. Again, life expectancy is influenced by many different factors: quality of care, access to prevention, access to medical services, lifestyle, diet, violence, accidents. Okay, one last chart to further drill home the challenge of unequal death. This argument is further magnified when we look at disparities in life expectancy across the globe. People living in developed countries can expect to live much longer than those living in developing countries. In Japan, Australia, Canada, life expectancy 82, 83 years. In Ethiopia, 64. In the Democratic Republic of Congo, 60. In Malawi, 58.3. 20 years difference. That's a lifetime. That's as old as some of you are in this room. A lifetime. Given the scarcity of resources, it seems to me that we have to focus on reducing some of these disparities before we put a lot of our energy into radical life extension. Now, having said that, I'm not so naive to think that you can stop the biotech private industry, where they see some exciting potential here and they're investing tremendous resources in looking at radical life extension. But I do think that public resources have to be channeled to improving the unequal death scenario, and I also think that we should look at incentives for encouraging the business community to also think about how we can pull from interventions that we know work and bring them to places that are in desperate need. Having said all this, the life expectancy escalator marches on for now, with mortality rates declining at a rate of 0.6% each year. Demographers predict that longevity will continue to increase. For nearly 2 centuries, life expectancy has risen about 3 months a year despite 2 world wars, a huge influenza pandemic, the AIDS epidemic, and the growth of the global population. The U.S. Social Security Administration predicts people born in 2030 will have a life expectancy at birth of over 84 years. People born in 2075 will live more than 87 years, on average. Slow but steady lengthening of the lifespan. It's independent of any single event or factor, and that is happening globally. Of course, if anti-aging drugs or therapies are discovered, the escalator could ride higher, and living to 100 could become the norm. But there's no question that even without radical life extension, the population is aging. When we typically look at population pyramids like this, we usually think about pyramid in the shape of the classic pyramid, in the shape of a triangle. And that's what it's looked like for a very long time, with a very large base of very young individuals, and then those bars slowly decreasing as you go up the age spectrum. However, the population pyramid today looks more like a dome, or like the U.S. Capitol. And if you look forward to 2050, we see that the dome smooths out at the top, with an increasing number of people at the upper domain in 75, 80, 85, 90, etc. So what are the implications of this aging population? Many articles have been written on the implications. There are concerns around workforce and labor market. People are concerned that maybe the workforce will grow more slowly. There'll be more labor force participation at older ages. Could this have an impact for younger workers? Will there be more competition and fewer jobs? People are worried about the healthcare workforce. Do we have a sufficient supply of providers to meet the needs of the aging population? What about caregivers? We all know that many of us are caregivers, informal caregivers with a full-time job and with a family, and there are new kinds of innovations or programs figuring out how to incentivize people to stay in that role, because we will need people to be informal caregivers, as well as how to shore up the formal caregiving workforce. What about housing and public policy? We're going to need new kinds of housing. We're going to have to think about homes that are affordable and accessible, located closer to social and commercial centers. We're going to have to rethink transportation. There's greater risk to the sustainability of Social Security and Medicare and other public programs. It's likely that we're going to see these programs struggle to meet the needs of the population, particularly if we have a smaller proportionate population paying taxes in because the younger workforce is shrinking. What about risk to environmental sustainability? We're already concerned about overconsumption due to growing global population. What if people continue to live longer and longer? What will that do to our scarce resources in the environment? And health care and health in general. Do we have the infrastructure? Where will we care for people as they age? What if they age with more chronic illness? Our health care system is right now woefully unprepared, given the numbers, let alone what the projections are. We'll need to do a better job at preventing premature deaths at the younger ages because we might not have the resources available for that population. This is often what's discussed. We need to promote a healthy lifestyle early because that could reduce rates of chronic illness. These are all issues that are discussed at length in the literature. So I wanted to talk a little bit about some new and some not so new innovations or responses to these implications. And there's some overlap here. And this is where I've done kind of more of my research, and so I'll talk a little bit more about a couple of these issues or these innovations. So one of them is that there's, fortunately, people see real potential for increased labor force participation at older ages. Actually, it could increase national output. It could decrease, the drawdown on retirement savings. It could limit the impact on public programs because people are working longer and paying taxes in. People might have a greater opportunity to do more saving. We might see people who are working second and third careers, staying in the workforce longer. And a lot of research has showed that it will have a limited impact on younger populations because we have some experience. We can look at Japan. We can look at some other countries that have actually further along in the graying of the population. And then I would like to talk just for a second about something called time banking and service credit programs, which I see as an alternate way to be productive in society. I think we're going to have to come up with new ways to help people maintain productivity, not only to shore up our communities, but to make people still feel connected, even outside the traditional labor market. So time banking programs are programs that create community networks of service exchanged based on time, not money. They build a core economy by valuing and rewarding work that's not always available or valued on the traditional market. It creates an environment of reciprocity where everyone's skills and talents have equal value. It's a way to link into untapped community capacity and to meet unmet needs. There are over 300 registered time banks in the United States serving over 30,000 members. And they also exist in 34 other countries, with over 200,000 members served worldwide. I think there's a tremendous opportunity here for intergenerational networks that connect older adults to younger populations. This is not a brand new innovation, but I believe and propose that its time may have come. There's lots of examples of the kinds of things that can be exchanged in these networks without the need for money or formal employment. Whether you're talking about translation services, support services, training, respite, transportation, home repair, tutoring, the list is really endless. A few years ago, I co-authored a book called Equal Time, Equal Value, which provided the first systematic evaluation of time banking programs. And we found that while they're difficult to fund and difficult to manage, they're an effective way to tap into community resources, and they can really revitalize communities. And I think that given some of the challenges we have with a population that's aging, it might be that it would become less difficult to fund or to find investors for these kinds of programs. In terms of housing and public policy, there are numerous cities and states that are advancing livability and accessibility. New public initiatives demonstrating the benefits of linking housing and long-term care services. The private sector is finally seeing a market and developing new housing options, accessible housing options, new technologies to assist those who have various kinds of disabilities, and new services. And again, I'd like to propose that a not-so-new innovation, naturally occurring retirement communities, or NORCs, are something that may be a resource we need to rethink. What are NORCs? They are apartment complexes or neighborhoods with high concentration of older adults who have aged in place. They moved there when they were young, and they stayed there and they aged in place. And now they may need some help to remain independent in the community where they would like to continue living. There are approximately 50 health and social service programs funded by New York State that serve NORCs today. And I worked for many years with the United Hospital Fund in New York City, developing blueprints for how health organizations could partner with social service organizations to bring integrated services to the aging population in NORCs. And the amount of NORCs, the numbers of NORCs, are only increasing because our population is aging. And there are a number of NORCs not currently being served by any kind of programs right here in Nassau County. Again, historically, really hard to fund these programs. But I'm arguing that today, not only because of the demand for this kind of service, but because there's a whole new way that we're modeling healthcare, we're rethinking how to deliver care. We're moving beyond delivering care just by providing units of service, and we're starting to think a little bit more about how to produce value. And if we're looking to improve outcomes and value, I would think that organizations are going to be looking for places like social service programs that can serve naturally occurring retirement communities as a partner. I think providers, health systems, hospitals are going to be looking for these kinds of integrated programs. So I think, again, this Innovations Day has come. In terms of health and healthcare, again, there's some overlap here. I just mentioned there's some new models of care, team-based care. We're thinking about it a little bit differently, and it's much more focused on improving and coordinating care for those with chronic illnesses. Telehealth offers opportunities for distance provision of healthcare services. There are some really exciting experiments happening around telehealth, particularly for the chronically ill and elderly. And there's some new exciting evidence in the very current research, this past month in the Journal of American Geriatric Society, showing that for every year of healthy lifestyle promotion while you're young, you can lessen the amount of time spent disabled when you're older. So this is something that we've known in public health for a while, but we needed the data and the evidence to perhaps convince others that there should be reimbursement and investment in healthy lifestyle promotion when you're young, and it could change the way things look when you're older. So I would like to reframe the discussion from implications to promises or opportunities of an aging society. Several researchers are exploring advantages of demographic change, and they see a more productive, greener, happier, and healthier society. They see a society with increased productivity because the older population is more educated. They're pursuing second and third careers based on passion. They're engaging in a retirement track, not necessarily work retirement, but a path where they are changing the way they're involved in the labor market, perhaps working at different levels in different places. Greener because there's lots of evidence that older adults actually don't use as much energy-intensive goods, somewhat less materialistic, perhaps drive less or prefer to drive less, so we might see lower carbon dioxide emissions. More walkable communities could result in less use of cars. Healthier, because we are practicing healthy lifestyle promotion earlier. Exercise could become something more routine and embedded in daily lives, and therefore compressed disability. Happier, because there could be a greater sense of community. People might have more time post-child rearing years to develop relationships and friendships. There could be reduced ageism because of the demographic shift. The most exciting research being done in longevity science concerns making later years vibrant and increasing not only the lifespan, but the health span. And I think this should be really our overarching goal. And I would like to invite you, in closing, to continue the conversation about how we can foster a vibrant aging society. On Tuesday, November 29th, in just less than 2 weeks, we have an all-day free conference that Hofstra is hosting called Shifting the Perspective, Aging and Creativity. And there will be providers and policymakers and practitioners and administrators, as well as community members, talking about opportunities for enhancing the vitality at advanced ages. And all students and faculty and community members are invited. And I truly believe it'll change the way you think about growing older. So if you'd like to learn more about that, there is a conference agenda outside that you can pick up, or you can visit agingcreativityconference.wordpress.com. These are just a couple of selected references. There are some really interesting readings for those who would like to dig a little deeper into some of the concepts that I just briefly introduced. You can certainly email me, and I can send you a more extensive list of references or suggested readings. My cards are outside. Thank you very much. So I think we'll take some questions from the audience.
We ask that the audience members come on down here to ask the questions.
Or comments. We take comments too.
Hi, thank you so much for your talk. I really appreciate it. It makes me really look forward to aging, I think. I have a question. So when you talk about the investment that's being made by biotech companies and other agencies to really think about the shifting genetics and other ways to sort of tinker with increasing the age span, I mean, it seems to me that the evidence of what's worked in the past, which is increasing quality of life, access to healthcare, but also really just like the environment, as you mentioned, has doubled the lifespan. Why the lack of investment in things that have clearly worked versus sort of the experimentation that might have unintended consequences?
I think it's such a great question. I mean, it also forces us to think about why we pay for certain things the way we pay for them in the current healthcare system. I think technology is very exciting. I think the pull of the unknown, I think, is something that tends to lend itself more to people who are making these tremendous investments. In Silicon Valley, there's a hedge fund manager today who, I don't know if you've heard about this, but has put out a $1 million prize called the Palo Alto Prize for anybody who could crack the aging code. And so 15 teams of researchers from across the country have entered into this contest. And so there are different kind of levels. They only have to meet the first level and they could make $1 million, and then he's willing to dump more money in and more money in and more money in. And he has 50 advisors who come from prestigious institutions across the country. And you'd think maybe some of them would say, what about a prize for trying to reduce some of the disparity? What about a prize for improving access to clean water in the Congo? What about a prize for trying to figure out why it is in the South that our life expectancy continues to be low? But that message is not either getting across or just not exciting enough at this stage. Maybe some of you young entrepreneurs will take that on.
You mentioned this is an exciting field for you because the intersection of so many different things that you're involved with. And I've been a futurist since the early 80s, and I'm a big fan of Ray Kurzweil's work and everything else. But one of the major criticisms I have with him, for all his genius and life extension, is he totally omits the political aspects. He's a science guy, and he never. And so that's what I'm very concerned about. You mentioned Social Security, Medicare. There's easy fixes for this stuff. I mean, you lift the payroll tax, the Social Security payroll tax cap, you're done. Is it? But we won't do it. So there's, like you're alluding to here, there's zero political will for these things. And I think the forecast is very dire, and we're seeing it now. There's that growing gap, and it seems to me people are left to die. I mean, there's no political will or effort being addressed here. What's your forecast at? What do you see? Where's the hope here? Give us some hope.
The only thing that really does give me some hope is that we are really changing some of the models of care. And as my students in the room will probably companies shudder as they hear me say this. Form really follows financing. For largely the reasons why you're talking about, we change our behavior based on where the incentives are. And we are changing the way we are structuring the healthcare system, regardless of what happens to the Affordable Care Act. This is a movement that's happening, and that is that we are looking for more value, and we're not just paying based on units of services provided. In order to get to the value, in order to get to the better outcomes, we're going to have to do care differently. We're going to have to deliver services differently. And it's going to require a focus on the social determinants of health, because that's what's driving poor outcomes in healthcare. It's not that we haven't figured out the medical services. We have that part down. But that's only one small piece of the puzzle, one piece of the formula. And so if we have to get to value, it's going to necessitate a recognition of the other side of the formula. And that's where I have some hope.
Informally isn't, or at least what I think I see happening is you get these naturally occurring black markets. I mean, you get that, again, that income inequality, and you have the formal care, and then you have this whole other track that people are just adapting to the conditions. And a lot of what you're saying is naturally evolving, but not as necessarily part of the kind of a fully integrated system. You get a two-tier system.
Right. I mean, there is a two-tiered system. I don't necessarily foresee some of that changing quickly, but I do think that because there will be a recognition that in order to continue to maintain some of the reimbursements, you have to do some things differently, and people are going to want those reimbursements, and they'll change and move the system a bit. I do believe that's true. I also do believe in some of those, lower tech kinds of innovations that I think have potential. I think that we could see greater investments because the demand will come from the community as well, looking for ways to stay connected, looking for ways to stay productive. So I don't think we can solve a lot of those problems, and I think a lot of what's happening in private industry will happen simultaneously, but I think we have to work at both ends. Thank you for your comments, that was true. Anybody else, questions or comments?
Hello, I have two questions actually. So you talked about older folks becoming productive as they age. What do you expect, for example, unskilled workers to be doing? Unskilled workers.
Unskilled.
So unskilled, correct. So of course, I could see ways that workers with a lot of knowledge, expertise, etc., could remain productive at that later age. But for workers that perhaps are just in service jobs?
No, it's a really good question, and I didn't focus on education and training, which is another whole area where there has been some movement. Universities are starting to be more responsive and thinking about people who are coming back for second and third careers. Again, that's a costly alternative, although maybe there'll be some movement in that area to create training programs that are less costly. I think that one of the things that we can expect to see is a need for rethinking about second, third careers. So some of it, I spoke about as being things you could pursue that you were always passionate about and didn't have a chance, but there are others who are going to need retooling to do things that can be maintained at advanced ages. On the flip side, that's exactly the point of the time banking programs, that they're supposed to foster a recognition that everybody has something to offer, and it doesn't necessarily require the traditional skills in the labor market. So I don't think that's a complete solution, but since you are exchanging services, meaning that you can then dip in to get other kind of services, it does create a currency where you can, have some element of participation in buying and selling things, but with your own services, whether it's translation or phone call or friendly visiting or home repair, the kinds of things that really lots of people can do.
Right, and for my second question, which obviously countries like Japan, with their falling birth rates, it's a significant issue. I may be mistaken, but are there any aggressive solutions that could help resolve this? I mean,
That come out of Japan?
Not that come out of Japan, because I don't believe they've figured it out yet. But I mean, this might sound ridiculous, but would there be a possibility to somehow make it necessary for certain parts of the population to have higher birth rates?
To have what?
Higher birth rates, like women, for example. Obviously, this, you know, is
you know what I think will happen instead, and what we're seeing here and in some other places, a little bit less in Japan, but in other places, and that is immigration rates that really do keep the average age lower. I mean, there are predictions in the United States that we wouldn't go beyond an average age of 41 for 40, 50, 60, 70 years because of how high the rates of immigration are in this country and others. So I think that, you know, another reason why we should foster immigration, and it keeps a vibrant working society. There's lots of reasons to do that. Obviously, the political structures, you know, need to have the political will for that to happen, and that may not be the case. But in terms of, you know, forced, you know, fertility or increased birth rates, I don't have really any comments about that. I don't know. Thank you, though.
I'm loud, so I don't know if I need the microphone, but I have a question. Oh, okay. Let's say you're magically appointed the aging commissioner for Nassau County. I hope you never leave Hofstra, but let's say that happens. What do you think should be, you know, the priorities for our own older adult population right here in Nassau County?
It's a good question. I absolutely would, you know, look into investing in social services. I mean, I think that that's critical. I want to see greater connection between the social service and healthcare organizations. I mentioned that some of the work that I did at the United Hospital Fund was specifically around linkages, how to better improve the linkages. Oftentimes the linkages are one-way linkages. They're only based on referral and not necessarily on shared decision-making and shared care. And I'd want to see, there are lots of innovations around the country that show that that can be very successful and can care for and better for people at all ages with chronic illness. So absolutely, I would think, you know, I would encourage that, you know, at the between social services and the healthcare system.
Hi, my name is Richard. I just wanted to comment on something you said. I'm not studied aging, but I'm certainly living it right now at age 79. But it has its problems. But, you know, I was thinking as you were talking, I remember in 1947 or 48 reading about Cortez, I think it was, one of the explorers in Florida looking for the Fountain of Youth. Here we are all these years later talking about it in a sense. But one of the things you really touched upon was, for me, was you said looking at aging as a disease. Wow, I said to myself, that's really something, looking at it as a disease. Could you comment on that?
So that's one of the arguments that's often made by those who are supportive of like radical life extension, and they really think that this is something that can be cured and not just an evolutionary process. I don't necessarily agree with that. I don't think that there's this boundless upper limit. I really believe much more in kind of an evolutionary theory, and I believe that we can do a lot to increase the health span within that natural course. So are there aspects of aging that we can improve upon? Probably, but I don't think of it as a disease that can be cured. But that is one of the prevailing arguments that's out there. And a lot of these companies that are supporting life extension research, they tend to think of it like a magic pill. I mean, I like the fact that you brought up that comparison to the Fountain of Youth, because that's often something that's argued when people are looking at radical life extension. They said, you know, this is again, you know, searching for this magic pill that can turn off, you know, the clock. And that, I don't think that the majority of researchers see it that way.
I have a question for you. You know, it's interesting when you take a look at the politics of this, as some folks have mentioned. And I'm struck because Long Island is in the process of really working hard to try to keep educated young people on Long Island. We've been building apartment clusters near train stations. We've been really aggressively building a job market for young people to stay on Long Island. But if you read the papers about development for housing or services for older Long Islands, there's a lot of community resistance for that, and much more acceptance of building infrastructure for young people. And when you look at the age, the population pyramid, if you will, for Long Island, it's much older than the rest of the population of the United States because young people tend to leave the island, leaving older people behind. Are we in a crisis on Long Island with services and housing and general care for the older population?
I mean, I think that we are. I think we are at a stage that is going to require some significant rethinking in the older suburbs as well as around the country. I also think that there's tremendous stigma. I think that ageism is highly prevalent within society, and I think that that's a culture challenge for us. One of the reasons why we're having this big conference in 2 weeks, I mean, that's actually one of the areas, you know, and I talk to my students about this all the time. If you want to be assured a job, if you want, and a fulfilling one at that, if you want to always be employed, if you want to differentiate yourself on your medical school interviews or applications, talk a little bit, learn a little bit, think a little bit about the aging of the population, because that's really who you'll be serving, and that's the population that you'll be working with. And so I think there has to be some rethinking among young people about this. And I think not just young people, but people across the age spectrum. And it has to be reframed. It has to be a more positive. We have to look at some of the opportunities that it presents. Maybe Hofstra can play a role in that.
Well, I think that's it for questions. Please join me in thanking Dr. Kyriacou for a great lecture.
Release.